This is case of sinus venosus ASD of SVC type along with moderate pericardial effusion, and effusion is of exudative nature. In this image you see this is inferior vena cava. I indicates for inferior vena cava. This is liver, this is hepatic vein. S for superior vena cava, both are IVC and SVC, both are draining into right atrium. This is left atrium. Interatrial septum is lacking here, so flow from left atrium and flow from superior vena cava both are going into right atrium together. That is why we call it venosus ASD of SVC type. This is right pulmonary artery in transverse section. So left atrium, right atrium, this is superior vena cava, this is inferior vena cava, this is right pulmonary artery in transverse section. Image wise, this uppermost part of the skin is the most inferior part. You see the most anterior part, and this is IVC. You see this is the most inferior part, this is the most superior part, this is anterior part, and this is posterior part. Simply I want to write, then I will write like this. This is anterior, this is posterior, this is most inferior, this is most superior part. So now you understand this is anterior part, this is posterior part, this is most inferior part, this is most superior part. From inferior part, inferior vena cava, most superior part, superior vena cava. So structure wise, now you know this is pericardial effusion. E for effusion, pericardial effusion. You can see fibrin bands. If you just see the size of SVC and IVC, you see this is the size of SVC, 12 millimeter. Now size of IVC, only 8 millimeters. So whenever the size of SVC is more than IVC, that means there is abnormal flow. So in this case, SVC is getting blood from right upper pulmonary vein. At the same time, both blood, SVC blood and blood from left atrium goes into right atrium at the same point. That is why we call it sinus venosus ASD, because both are very close to each other, almost joining each other. That is the point to understand this image. Now the next image, again the same thing. This is IVC, this is SVC, this is hepatic vein, this is left atrium, this is right pulmonary artery in transverse section view. Again the same thing, same image, same window, subcostal window bicaval view. This is IVC, this is SVC, this is this is right pulmonary artery in transverse section, cross sectional view. This is right pulmonary artery, this is left atrium, and both flow from left atrium and SVC goes together into right atrium. Now you see the color flow. You can see the color flow, more blood flow is going into right atrium through SVC, and this is the ASD flow. You can see this is the ASD flow. You can see this is the ASD flow. This is the ASD flow. In this view, this is right atrium, this is left atrium, and this portion is ASD, and this is the portion is superior vena cava. This is right pulmonary artery and cross section. So this is right pulmonary artery in cross section, this is left atrium, this is right atrium, this is ASD, sinus venosus ASD of SVC type. This is pericardial effusion, and effusion has fibrin band. You can see fibrin bands, and fibrin bands indicates infective in nature. In developing country like India, most likely diagnosis tuberculosis. One can take history of fever of long duration, that will give you finding in favor of tuberculosis. Sometimes viral infection can also cause similar finding. Now you can see the flow across ASD. This is left atrium, this is right atrium, and this is the flow ASD. Most likely this one is right upper pulmonary vein draining almost into SVC. Right upper pulmonary vein. This is right pulmonary artery in transverse section, and this is right upper pulmonary vein draining into SVC and then into right atrium. You can see same image without color. Again you see the right upper pulmonary vein draining into right atrium. So apical fourth chamber view, you can see some pulmonary vein. Here the some pulmonary vein draining directly, almost looks like it is draining directly into right atrium. Instead of left atrium, pulmonary veins should drain into left atrium, but abnormally it is draining into right atrium. It appears in this image because everything is very close to each other. Right, actually it is draining into vena cava, but so near to right atrium it appears that it is draining into right atrium. So whenever you find right upper pulmonary draining into right atrium, then there must be sinus venosus ASD of SVC type. That is the practical learning. That is flow across tricuspid valve. Now you can see short axis, pastern short axis view. You can see this is fibrin bands. This is parietal pericardium, this is visceral pericardium, and both is having fibrin bands. Effusion is more in this portion. Why this portion has got more effusion? Because of gravitation. So most dependent part will have more pericardial effusion because free fluid is present in pericardial space. Fourth chamber view, you can easily appreciate right atrium and right ventricle severely dilated in this case. Though case has got moderate pericardial effusion, at the same time right atrium, right ventricle severely dilated, so case also has sinus venosus ASD. This is left atrium, this is pulmonary vein, left pulmonary vein. This is right atrium, this is right ventricle. Right atrium and right ventricle severely dilated. Again this is subcostal view, fourth chamber view, and now you can see the pericardial effusion and significant fibrin bands. This is coming from visceral pericardium and this also from parietal pericardium. The effusion just inferior to right ventricle, 3.6 millimeter. Again this fourth chamber view. Effusion more, you can say lateral to left ventricle. This portion has got more effusion. The short axis, pastern short axis view. You can see effusion 1.8 millimeter in this space. The definition wise measurement should be posterior to left ventricle at the atrioventricular point. So here it is less than this one. So this case has got only moderate pericardial effusion. Measurement ideally should be here. So only around 10 millimeter. So this case has got moderate pericardial effusion. Severity of pericardial effusion criteria wise and diastolic effusion behind the left ventricle, that is posterior to left ventricle, posterior to posterior wall, near atrioventricular junction. If it is less than 10 millimeter, then mild, 10 to 20 millimeter moderate, more than 20 is severe. And pericardial effusion seen only during systole is trivial. So below 10 mild, 10 to 20 moderate, and above 20 severe. Just remember 10 to 20, that is moderate one. If it is moderate 10 to 20, then moderate. If less 10, then it is mild. If more than 20, then it is severe pericardial effusion. In fourth chamber view, you can clearly see no right atrium and right ventricle collapse seen in this case, indicating absence of tamponade. One thing, important thing is there, because when there is ASD, so right atrium, right ventricle is already volume overloaded because of ASD. So tamponade will be appearing late in this case. Even the tamponade, suppose clinically tamponade like finding is there, but echocardiography you will not get because of volume overloaded condition or pressure overload. Whenever there is pressure overload or volume overload of right atrium, right ventricle, because pressure overload can also be seen because of volume overload. So whenever right atrium, right ventricle has got more pressure due to some other diseases, then early tamponade will be missed, because it will not be easy for pericardial fluid to compress right atrium, right ventricle, because already it has got more pressure than normal expected pressure. So in this case, right atrium, right ventricle is severely dilated because of ASD. Though this child does not have the clinical feature of tamponade, but echocardiographically you don't find any finding of RA in right ventricle and right atrium collapse. So no finding, no evidence of tamponade. Only thing I want to say in this video, that whenever you see the causes of right atrium, right ventricle pressure to be high because of some other pathology, in that case early case of tamponade will be missed. So you have to see the status of the patient also to interpret the physiological finding of echocardiography. So early case of tamponade will be missed. Though in this case does not have tamponade, clinically patient was not having such degree of shortness of breath. Thank you.